Welcome to session 10 of Oxygen Therapy and Critical Care, the case-based series. We're very excited. Today we'll be talking about obstetric considerations for oxygen therapy. And as usual, we have our panelists with us today. So before I hand it off to them, just a couple reminders. If you have any questions throughout the session, please put it in the chat box and we'll be happy to answer when we get a chance. And if you have any technical challenges, please also put that in the chat box and myself or a colleague will be happy to answer this as quickly as possible. So I will hand it over then to our panelists to get us started. Since Dr. Papytcho is not quite here yet, I guess Dr. Hope, would you like to give the introductions then?
Yes, sure, Sarah. We can go to, good afternoon, participants. Welcome to Dr. Papytcho's Oxygen Therapy and Critical Care, a case-based series lesson plan. For this afternoon, we have our three usual panelists. There's myself, Dr. Hope, there's Dr. Ndava, and there's Dr. Papytcho. So I've seen Dr. Papytcho has just entered. I think he will take us through the practice change and learning point objectives for today. Dr. Papytcho, the floor is yours.
Thank you very much, Dr. Hope. I had some challenge to join. My internet was dropping. I've managed to come on board. Today's presentation will be a case discussion on a 28-year-old pregnant woman who presents with fatigue and shortness of breath. This falls under obstetric consideration for oxygen critical care. And the discussion will be an open one. We will advise that all our participants to be very interactive during this meeting. And we'll first start by highlighting some points that has been emphasized by WHO, which is that maternal mortality is unacceptably high. As we know, even here in our country, it has become a very big issue. Maternal mortality is being fought from the highest office. This is to show how serious we've taken into consideration the issue of mothers dying during pregnancy or giving birth. So WHO tells us that every day, approximately 810, this was in 2017, a woman died from preventable causes. It means a cause that we can do better to avoid the mortality, but we fail to do it, and then the woman ends up by dying. Majority of maternal deaths occur in low middle income countries. 94% of all maternal deaths occur in our environment. So this is a very high rate of mortality. It's all our responsibilities to do best on how to fight maternal mortality. And maternal mortality is most among adolescents. Young girls who are coming for delivery, they end up dying for different reasons that we are going to discuss in this discussion lecture. Our practice change objective for today to be to list the physiological changes that occur with pregnancy and describe how physiological changes of pregnancy affect maternal well-being. Our third objective will be to describe how physiological changes of pregnancy affect disease presentation. And then we'll try and describe the changes in arterial blood gas that occur during pregnancy. We'll list the goals of oxygen therapy in pregnant women. We'll recognize and describe signs of maternal distress. We'll also recognize and describe signs of fetal distress. We'll list the multidisciplinary team members required for optimal care of a critically ill pregnant patient. We'll describe the unique consideration during resuscitation of pregnant women. We'll utilize cognitive rates for obstetric emergencies. And last not least, we'll be able to access COVID protocols for obstetric patients. So these practice change objectives lead us directly into the case presentation, which is as follows. So the history of our patient, as we announced it on the introduction, it's a 28-year-old pregnant woman with gestational age of 29 weeks who present with fatigue and shortness of breath. Her symptoms started 2 days ago with a stuffy nose, a running nose if you like it, and feeling of fever. Although she has not checked her own temperature, her pregnancy has been uncomplicated, but now she's concerned that she does not feel much fetal movement for the last day. She is a teacher. She's not aware of any exposure to SARS-CoV-2, that's a virus responsible for COVID-19, but she does interact with children daily. Her obstetric history, she has 2 previous uncomplicated term delivery. Her past medical history, she's known to have hypothyroidism. Surgical history, there's nothing specific. Her social history, she lives at home with her mother and her 2 children and her husband. She's on levothyroxine and she has no known allergy. So from this case presentation, we'll invite Dr. Opp to take us through the case discussion.
Okay. Thank you so much, Dr. Papytcho. Sarah, can you please scroll down? Okay, so for this segment, the practice change objectives are to list or understand some of the changes that occur during normal pregnancy. So these are physiological changes. We want to see how these changes affect the maternal well-being. We want to see how these changes affect the disease presentation in pregnancy and how the physiological changes in an arterial blood gas in pregnancy, how the picture is like, how it's different from the non-pregnant population. So to start the discussion, I've got 3 to 4 questions, but before we go through the questions, I want us to watch a short video and let us understand how these changes affect the different systems of the body. In the video, we'll focus on the respiratory system, the cardiovascular system, and the hematological system. Sarah, please scroll downwards to the video. There we go. Yes, on your right-hand side. Yes, please. Let's go to minute 56.
The pregnancy. So let's start with the cardiovascular system. First, there's some anatomical changes that we need to talk about. The heart is displaced left and upward, and it's rotated on its long axis in pregnancy. This is important because where you listen for heart sounds is a little different than in the non-pregnant patient. So now let's think about the physiologic changes within the cardiovascular system. So we notice that the systemic vascular resistance changes. So how do you think it changes? Does it increase? Does it decrease? Well, in fact, it decreases. And this is the reason in the first and the second trimester, we notice that the blood pressure also decreases. Well, when we think about the mean arterial pressure, what do you think happens there? Does it increase? Does it decrease? It, in fact, decreases as well. Our heart rate also changes in pregnancy. What do you think? Does it increase or does it decrease? The heart rate also increases in pregnancy. And lastly, cardiac output. Do you think it increases or decreases? You probably guessed right. It increases. In fact, it increases to almost 15 to 40% in the first trimester and even more during the labor process. So now let's move to the hematologic system. That also changes in pregnancy. First, we notice that the blood volume increases to 40 to 45% above the non-pregnant patient. This is mostly because of increase in erythrocytes and in plasma, and we notice that pregnant women have a physiologic anemia because of this increase. So what else changes? Well, our iron requirements also increase in pregnancy. Some of that can be met in the diet, but in some pregnant women, they require iron supplementation to meet that increased demand. Now, our immune system also changes in pregnancy. We're not exactly sure why that happens, but we do know that the immune system is blunted in pregnancy, making pregnancy an immunodeficient state. Now, lastly, but most importantly in the hematologic system, pregnant women are hypercoagulable. That means their blood is thickened, and because of that, they're at increased risk for deep vein thrombosis as well as pulmonary embolism. This is important to think about as this can be a huge cause of maternal mortality, especially in light of patients that undergo C-section. Surgery, we know, increases our risk of DVT, and pregnancy, because it is a hypercoagulable state, also increases that risk. So we need to be sure to watch out for that. So now moving on to the respiratory system, there are some anatomic as well as physiologic changes in that system as well. First is the change in the diaphragm. We notice that that rises by 4 centimeters. Can you think of why that may be? Well, let me tell you, the uterus is increasing during that time. As the uterus gets larger, the diaphragm gets pushed up as well. So how does that affect our physiologic changes within the respiratory system? Well, the functional residual capacity decreases. And again, that's just because the diaphragm is pushing up, so that residual capacity decreases. The total lung volume, however, does not change. Our expiratory residual volume and our residual volume also decrease. And then when we think about our tidal volume and our minute ventilation, they both increase. So this is a nice diagram that puts all those things that I just told you into one big location. So I would make sure that you go through this in a lot of detail to make sure you understand those changes in the lung volume, as we previously discussed. Question.
Sarah, thank you so much. We can pause the video. Okay, we'll now look at our questions for today. That video just went through the 3 systems actually, and some of the information we need to know about the physiological changes. For those who are requesting for the link, please register to the Learning Resource Center where all this material is available. So just to test our knowledge on the video, we're going to go through a series of questions. This is going to be a self-poll. So this is going to be a sort of self-introspection to see if we're familiar with the physiological changes of pregnancy. So the first question, each of the following are normal physiological changes in pregnant patients, cardiovascular systems, except, so A, we have increased cardiac output due to increased heart rate and stroke volume. B, dilutional anemia from increased plasma volume. C, supine hypotension syndrome. D, aortocaval compression by the gravid uterus. Or lastly, increased blood pressure due to high systemic vascular resistance. So participants, I encourage you to choose an answer from these responses based on the video that you watched or based on your prior knowledge. So as you think of these changes, obviously looking at the video, we know that the answer, which all of these statements are correct, except the last one. In pregnancy, the blood pressure actually reduces, as we heard in the video, due to the low systemic vascular resistance, which develops due to the action of hormones, maternal hormones such as progesterone. So we can scroll downwards. Okay, So here we have another question relating to the physiological changes. Each of the following are normal physiological changes for pregnant patients' respiratory system except. So all of the following are correct except A, we have decreased oxygen consumption, B, increased tidal volume and respiratory rate, C, respiratory alkalosis, D, decreased FRC, which is the functional residual capacity, or the last one, rapid desaturation during periods of apnea. So which of the following changes are correct? Which of them are correct? All of them are correct except. So we know that looking at the video, we were told that the oxygen consumption actually increases in pregnancy due to the increased demand by the mother and the developing fetus. So we know for sure that oxygen requirement increases. So A is the correct answer. Let's scroll downwards, Sarah. So we have another question. This one is a true or false question. Dyspnea is common in pregnancy, occurring in 60% to 70% of healthy pregnant women. Is this a true statement or a false statement? Please have a self-poll for this. Okay, so at your own time, please visit the Learning Resource Center. And when you click on the question mark on each question, you will be taken to some resource material, which you can read, previous studies and other resource centers, which will tell you what the correct answer is. But we do know that it is true. Dyspnea is common in pregnancy and occurs in healthy pregnant women with an occurrence rate of 60 to 70%. I'll move on to the second last question. So here we're talking about the arterial blood gases. In previous lectures, we've talked about oxygenation. We've talked about measuring the adequacy of oxygenation. So here we're looking at the pregnant population. The question reads, pregnant patients have an increase in their tidal volumes and respiratory rates through the normal changes of pregnancy. So what changes would you expect to see on an arterial blood gas? So in the interest of time, since we've gone through the video already, we know that there are a number of changes which occur during pregnancy. One, the partial pressure of arterial oxygen is going to change. There's going to be an increase in the partial pressure of oxygen. Sarah, you can actually click on the question mark so that we go to the resource. You can scroll downwards. There's a table down. I'll tell you to stop. Okay, keep scrolling. Keep scrolling down. Okay, just there. Oh, you missed it? Just scroll back up. Yes, there's a table. So here we're looking at the AB changes in comparing early trimester, late trimester, and the non-pregnant population. First of all, we know that the partial pressure of oxygen is going to increase. In the non-pregnant population, if you're using millimeters of mercury, it's about 90 to 100. But in the early trimester, it actually increases to about 106 and starts to reduce in the last trimester. In terms of carbon dioxide, initially the partial pressure drops. So it drops, there'll be a drop of about, it will drop to about 28 to 29, comparing with the normal of 35 to 45 in your non-pregnant population. In the third trimester, there'll still be a further, there's still a drop, a wider range, of course. However, one thing that you can notice looking at these parameters is that pregnancy is a chronic respiratory alkalotic state with an element of metabolic compensation. If you look at the level of bicarbonate, we see that in the non-pregnant population, the normal bicarb is 22 to 26, but in the first trimester, it's 18, and in the late trimester, there are values of 18 to 21. So this bicarb is a renal compensation compensatory mechanism to the respiratory alkalosis that we have. If you're to check the base excess on our ABG, you'd find that in pregnancy, the base excess could be between 2 to 3 millimeters equivalent. So these are some of the changes that you're going to see on your ABG. So I think we can go back to the main presentation, Sarah. Okay. In the last question is tied to the table that we see below. We know that for obstetric mothers, or for the obstetric population, they are prone to dyspnea, as we saw, 60 to 70%, and therefore this makes them prone also to acute respiratory failure. So we need to be aware, we need to know which conditions cause acute respiratory failure specific to the obstetric population and also to the non-pregnant population. So the common causes, obstetric causes of dyspnea are many. Several studies have been done. If you click on the pen, which is next to the question, there's a resource, there's a journal article, which has shown some of the changes which occur in pregnancy, or some of the findings for acute respiratory failure and dyspnea in the pregnant population. So I'll sum some of them. I think participants can do this at their own time, Sarah. We can go back to the presentation. So some of the causes that have been found, they're multi-systemic. So depending on the different organ systems. So I will actually classify them according to the conditions that we commonly see in pregnancy. We know that hypertensive disorders are common. We've got hypertensive disorders of pregnancy, our preeclampsia, our PIH. All of those, once they're complicated, can lead to dyspnea and ultimately acute respiratory failure. We've got conditions such as amniotic fluid embolism. This is something that we always need to be on the lookout for. We've got conditions such as ovarian hyperstimulation syndrome. We need to be looking for some of these causes as well. We need to look for acute fatty liver of pregnancy. We need to look at peripartum cardiomyopathy. This is quite common, but you may miss it if you don't look for it. We need to look for chemical pneumonitis, causes of chemical pneumonitis in pregnancy. Tocolytics, which we use also during the peripartum period, can cause what we call a tocolytic-induced pulmonary edema. Chorioamnionitis, for those who are in the early trimesters, we've got septic abortion, retained products of conception as well, endometritis. All of these can cause acute respiratory failure. So we need to make sure that we treat these conditions and we don't let them complicate. Non-obstetric complications are same as non-obstetric causes of ARF, acute respiratory failure, are similar to the non-pregnant population. So we've got DVT, which is quite common, and it was emphasized that pregnant women are at more risk because they're hypercoagulable. Cardiovascular diseases, hypertension itself, asthma, respiratory infections such as COVID that we're talking about today. So all of these can present as dyspnea, and they can complicate into acute respiratory failure. So the table just sums this in a system-based manner. Okay, I think we can move down, Sarah. Just scroll down. Okay, so once again, I would like to encourage you to go through the resource material on the Learning Resource Center. All of this is explained in more detail. So I'll hand over to Dr. Ndaba to give a case update. Dr. Ndaba, are you ready?
Yes. Sorry.
Please carry on.
Yeah, thank you so much. Yeah, and again, welcome our participants. Yeah, so I will take you through the case update. So this patient is now found to be having contractions, but these contractions are irregular and also occurring approximately every 8 to 12 minutes. However, her cervix still remains closed. In terms of vital signs, her temperature is 38.9, obviously febrile. Her heart rate is 115. Her blood pressure is 140/75. The respiratory rate is 18. And her oxygen saturation is at 91% on room air. The fetal heart rate is at 125 beats per minute. Sarah, we can scroll down. Yeah, so moving on, the following practice change objectives will be answered in the next session. So we are going to list the goals of oxygen therapy in pregnant women. We are also going to recognize and describe signs of maternal distress. And then we'll also recognize and describe signs of fetal distress. So the next discussion point comes in form of a question. So according to the Society for Maternal Fetal Medicine, which is a group of high-risk pregnancy experts, what is the goal oxygen saturation for pregnant patients? What is our target oxygen saturation for pregnant patients? So you remember that in our previous sessions, we discussed some of the goals of oxygen therapy or the target SpO2 for different kinds of patients. And pregnant patients were one of the categories that we had discussed in our previous session. So remember again that when you are classifying severe COVID-19, one of the criteria we look at is the level of the oxygen saturation. So we define severe COVID pneumonia as oxygen saturation of less than 94%, among other criteria such as the respiratory rate and also the presence of dyspnea. So according to literature, the goal of oxygen saturation in a pregnant mother should be above 95%, because we know that the oxygen demand and oxygen consumption for a pregnant woman is actually higher compared to other general patients. So their oxygen requirements are very, very high. So in terms of the target oxygen SpO2, we want to make sure that it's at least above 95%. And then also note that the amount of oxygen required to maintain a saturation of above 95% will really depend on, you also need to pay attention to what oxygen delivery device that you're actually using. So also you need to know that for non-pregnant patients, we can allow or tolerate an SpO2 of at least above 92. But for pregnant mothers, we want to make sure that the SpO2 is optimized, it's above 94%. Great. So we move on to the next question. We can scroll down, Sarah. So again, participants, I would like to urge you to look through our learning resource materials where you would find all this literature that is explained in detail. So the next question is, which of the following oxygen delivery devices can be used in pregnant patients? Which of these oxygen devices can you use in a pregnant patient? So we are going to take this as a poll. So we have 5 options: the Venturi mask, a mask with a reservoir bag, which is a non-rebreather mask. We have nasal prongs, and then high flow nasal cannula. And then the last option is all of the above. what do you think? Which of these oxygen delivery devices can you use in a pregnant patient? Are we able to take this as a poll, Sarah?
Yes, we are launching the poll. Eunice, are you able to launch that?
Yeah, so our dear participants, let's see what your opinion is. Which of these oxygen delivery devices can you use in pregnant patients? Yeah, there we go. Is it the Venturi mask? Is it a non-rebreather mask, nasal prongs, high flow nasal cannula, or is it all of the above? Okay, I think so far we are getting very interesting responses. And the most popular response is E, all of the above. Okay, and then we have other responses as well. So so we can end the poll. So all the above options can actually be used on a pregnant patient as well. Actually, in all patients in general, based on your assessment and based on the oxygen requirements, you can choose either of these 4 to deliver your oxygen. So the correct response is option number E. So you can actually use any of these devices, irrespective of whether it's a pregnant patient, it's a pediatric patient, any type of patient, you can choose among these oxygen delivery systems to deliver your oxygen. So we can move on, Sarah, to the next bit. I think at this point, I'm going to invite Papytcho to take us through the next segment. Thank you so much.
Thank you very much, Dr. Ndaba, for the nice discussion. At this point, we would like to give a case update. The patient we're discussing above is placed on oxygen by nasal cannula at 4 liters per minute. Initially, her SpO2 improved to 92, 93%, but an hour later, she requires 10 liters per minute by non-rebreather mask to maintain a SpO2 of 95. The air facility to which this patient presents does not have a neonatal care unit or staff to care for a preterm baby, nor does it have an adult ICU. The decision is made to transfer her to a center with the appropriate multidisciplinary team. So before we proceed down, I would like to make just a short comment in this case update. I'm sure participants remember that in our previous tutorials, we had discussed the oxygen delivery devices. And as Dr. Ndabe just from saying, you can apply all of them on a pregnant woman, depending on the clinical presentation. At times, some facilities might not have oxygen delivery devices as requested per escalation. In that case, it may be ideal to use what is available, but remember, when doing your escalation, do not give the lowest device, the device giving the lowest FiO2 as you are escalating. It's better you go up, and it's recommended to go up in terms of FiO2, and remember to give the ideal flow. And transfer of patient is also a topic that we discussed in the previous lesson. So here, it's actually a summation of the previous discussion that we've had, and trying to add up now a clinical practice or a clinical situation of a pregnant woman who might need transfer. So that being said, In one of systematic reviews, 75% of pregnant patients who contracted COVID were asymptomatic. As we know, COVID, 75 to 80%, they will come asymptomatic. It's just few of them that will come presenting signs and symptoms. So here the question is, what are considered danger signs for a pregnant woman that should prompt her to present for clinical care? Participants, you can just drop your comment in the inbox, and one of the facilitator will look at them and then will make a comment after you've make your own analysis of the case. We all know that fetal distress is a very broad term and has usually been used to present a baby who has changed condition when using the fetal heart or a CTG during examination. So obstetricians usually use this term to indicate that the fetal is becoming hypoxic and need immediate delivery to improve the outcome. Delay in delivering, it can lead to damages of neonatal neurological function by lack of oxygen. So antenatally, you can test the level of oxygen to minimize the risk of hypoxia in fetus. But we might not be able to do that in our settings. What we can is to use a CTG and the fetal heart count to identify when the baby changes condition, and then we rush fast for a decision to remove the baby by cesarean section or by other means to improve contraction of the mother. Sarah, can you scroll up? So when you click on the previous question, you will find that they will give you the danger signs for a COVID patient and a danger sign for obstetric patient. So when you look at these danger signs in a COVID patient, a woman who comes with COVID and a woman who comes for other, for just a normal pregnancy, but which becomes a danger. When you sum the two signs, it makes the patient to be again more ill and then who might need better care and intensive type of management. So at your institution, what are the options that you use to monitor the fetal well-being? I believe most of the institutions, they have the Phytoscope, which is simply a small instrument that you place on the mother's abdomen after locating the site where the baby, the fetus is lying, so that you get the beta sound of the fetal heart. You can do manual count, or you can do, using the CTG, the cardiotocography readings, and then the interpretation can be in favor of fetal distress or in favor of a fetus who just well. So we use our participants to go online using this material to try and read and understand what they call deceleration when it comes to fetal heart changes during cardiotocography. What is the implication of the rhythm changes during contractions, at the head of contractions, in the middle of contractions? What do you expect to get as type of readings? Okay. We have some different graphs on the learning material. So at your own time, go read and understand the interpretation of a CTG so that you speak the same language when it comes to a multidisciplinary team. Remember, we've been asked what are the people to come into the multidisciplinary team. It will not be fair if you are part of the team and you fail to understand the discussion just because you didn't know what is the CTG, what are the different trips, what does it mean at the end of the day when making up decision to deliver the baby. Thank you, Sarah. We can go back to the main page. So which one of the following is a reassuring sign of fetal well-being? Sarah, can we make this to be a poll question? Which one of the following is a reassuring sign of fetal well-being? Pick the best answer. Okay, Sarah, we can check our results. Oh, baseline fetal heart. This one, everyone got it right. Correct. I can see that we all have good knowledge about fetal monitoring, but still we encourage you to go read more so that we get to understand events more details. Thank you, Sarah. We can close the poll result. Next, I will invite Dr. Ndaba to come up with a practice change objective and further discussion on this case.
Thank you so much, Papytcho, for that wonderful session. So moving on, our next practice change objectives will be to list the multidisciplinary team members that are required for optimal care of a critically ill pregnant patient. So who do you think should ideally be involved in the care of a critically ill pregnant patient? Who do you think, in your opinion, would be relevant in providing care to this critically ill pregnant patient? So again, we'll still continue to invite you to our Learning Resource Center for all these materials on the guidance of the different levels of care for our obstetric mothers, from level 1 up to level 4, the criteria in terms of equipment, criteria in terms of specialization, etc., etc. So you would find this classification very well tabulated in our resource center. So I'm sure you must be thinking through some of the key individuals or key members of this multidisciplinary team that should be involved in the provision of care for a critically ill pregnant patient. So remember, critical care it requires a multidisciplinary approach, irrespective of the condition of the patient and the kind of patient that you are dealing with. So for an obstetric patient, it even becomes more obvious that you definitely need obstetricians or obstetric and gynecology specialists who are the key individuals in providing care of this woman. Then you need critical care specialists. You need infectious disease specialists as well. If you are dealing with the COVID patients, their input would be very valuable. And of course, you need midwives, because midwives, they will take care of the mother. They will be able to provide continued care to the neonate as well. Then you need neonatologists as well, because you are anticipating that once delivery, labor happens, you are thinking of the well-being of the neonate as well. So you might also want to have anesthesiologists involved as well, because this is a patient who might require emergency cesarean section in order to rescue the baby or in order to save the mother, as would be appropriate. So you may also need a full complementary support from other specific disciplines as well, such as hematology. You need your results. Some of the tests that you may be required to be done should be done on a daily basis, etc., etc. You need blood bank informed in the event that you need to take this woman for a cesarean section or any other obstetric complication arises. You may need other specialty also just to be on alert, such as in nephrologists, because we know that these patients can actually, one of the complications that may arise is renal dysfunction. So it's actually a full package of people that you may want to get involved at this particular stage as you provide care to this critically ill pregnant patient. So Sarah, we can move on to the next part. So what monitors then should you place on this patient? Remember, this is a critically ill patient, and so critical care monitoring is actually key. You're monitoring to see if there's any response to therapy or if there's any change in the condition of the patient. So what specific parameters do you want to monitor on this patient? So I know already our participants are already aware of some of the parameters that we would ideally want to monitor in this patient. So we want this patient to be on full cardiac monitoring, meaning that we need to monitor the blood pressure continuously. We need to continuously monitor the oxygen saturation. That's very important. We need to monitor the heart rate as well as the ECG in view of the complications that can arise in this patient. We also need to regularly monitor the fetal well-being. Papytcho just mentioned that you can use a Phytoscope, or you can use a CTG, a cardiotocography, just to monitor the condition or the fetal well-being as well. Remember, we have two patients, we have two individuals at stake. Yeah, so that would be your minimum monitoring strategy for this particular patient. So we move on to the next question, quite interesting. So for the patient's transfer, she is placed in an ambulance. So she is currently receiving oxygen by non-rebreathing mask at 10 liters per minute via a size E oxygen cylinder. So the pressure on the cylinder reads 2000 PSI. How long will the oxygen tank last before it runs out? This is very, very important, because we are all, we've been at one point or the other involved in the transfer of a patient that is on oxygen, a critically ill patient, maybe from one hospital to another, or even within the hospitals, maybe from the emergency department, you want to take this patient to HDU or ICU or any other ward, and you have to use a cylinder, and you may not be very sure when this cylinder will actually run out. So it is important before you actually take off to be able to estimate how much that oxygen will last, because once you run out of oxygen, you may actually lose the patient, because this patient is dependent on oxygen. So how long will the oxygen tank last before it runs out? So Sarah, I would like you to click on the question mark so that our participants can familiarize with how to go about calculating how much oxygen that would be required for this particular patient. So let's go. So you can already see that when you open this reference or this link, it gives you sort of different parameters in as far as oxygen therapy is concerned. So you have your different sources of oxygen listed there. Of course, if you are transferring a patient, it means you're going to use an oxygen cylinder. So on top there, you can see there's oxygen demand, there's oxygen supply and demand, and then there's SpO2 to PaO2 ratio, and then you have cylinder duration, okay? So we can click on cylinder duration, Sarah, so that we can now follow our case. So when you click on cylinder duration, here, this is where you calculate roughly how much or how long it will take before your cylinder runs out. So the first box there talks about selection of your cylinder size. You know, we have got different types of cylinders. You can click there, Sarah. So you are given the different sizes or types of cylinders based on the volume that of oxygen that they are able to contain. So for example, our cylinder here in question is a size E tank with, size E with a capacity of 680 liters. So we put that in. Then we enter the current cylinder pressure. So down there, so we have the current cylinder pressure. In this case, we are told that it's at 2000 PSI. So 2000 PSI. Again, remember, pressure has got different units. So you need to check your gauge, whether the units are PSI or kilopascals or bar. So again, you can select on the units. So this particular platform will calculate the equivalent of that value for you. And then you move on to the next box, which asks you to select the flow rate. The patient is actually receiving oxygen. So when you click there, you should be able to enter at what flow rate is the patient receiving oxygen, which is usually set by the user yourself. So in this particular case, our patient is receiving oxygen at a flow rate of 10 liters per minute. And then lastly, you go to the last bit where you are required to enter your default safe residue pressure. There's always a bit of pressure that remains in the cylinder, and by default, for a size E cylinder, it's 200 PSI. So you've already entered your parameters. And then when you come to the right side of the screen, you would see where it's written supply will last minutes or hours. And then according to our calculation, our supply will last 1 hour, okay? It will exactly last 1 hour based on our entry. And then the liters available in the cylinder at that current pressure, it will give you an estimate. And for our situation, our scenario, it's 612. So this is very important because you don't want to run into a situation where you run out of oxygen in the middle of the transfer, because you may actually lose the patient. There's a complex formula that you can use, but it's very difficult. And so this platform actually makes it easier for us. Once you open, and then you can just put in your values there, and then it will calculate for you how long that particular cylinder will last, depending on the size of the cylinder and the flow rate and the pressure of the current cylinder. So I would actually encourage all of us to familiarize with this particular system, because it might be helpful one day as you transfer the patient. We can go back to the main screen, Sarah. Yeah, so thank you so much. I would again urge all of you just to make reference to all these materials. They've got a lot of useful information that may actually help you as you take care of the patients. At this particular point, I'm going to invite Papytcho to come through and take us through the next section.
Thank you very much, Dr. Ndaba. I'm sure our participants are appreciating the information that you've shared with them. Especially when it comes to patient transfer, most of the time, it's a challenge when it comes to transferring a patient, not sure how much oxygen to go with and then what flow to give for me to reach my destination. And you find that they arrive maybe with a cylinder that's finished long before reaching the final destination. This should apply even within hospital transfer from point A to point B, not only from one institution to another one. Our case update, unfortunately, the patient status has worsened during transport to the hospital. She continues to contract and her cervix remains closed. Upon arrival, her status is as follows. The maternal vital signs, temperature is 39.1 degrees Celsius, heart rate 125 beats per minute, a blood pressure 105/60, and a MAP of 75. Respiration rate 24, a saturation 90% on 10 liters by mask with a reservoir bag. The fetal monitoring, the heart rate is 105 beats per minute. They've noticed that during analysis, there's a variable decelerations and minimal variability. Thank you, Sarah. We can move down. So after this update, our practice change objective is to describe what are the maneuvers or the unique or the most important maneuver that you have to do during maternal resuscitation in a pregnant woman. Utilize cognitive rates for obstetric emergencies and being able to access COVID protocols for obstetric patients. I'm sure all of us in our career have been encountered to a pregnant woman who changed condition and needs resuscitation. So our question here is, mention at least one unique intervention that you did to improve maternal well-being after you notice that your patient changed condition. You can drop your answer in the drop box. I would like to read our participants what is the unique maneuver that is really important during resuscitation of a pregnant woman. How did you do it? 1 or 2 words in the inbox. I'm checking the inbox. There's still no answer. Wow, okay. So if there's no answer, as we are progressing, we'll discuss that. Remember during pregnancy, what happened to a pregnant woman? The distended uterus, and for a patient, correct, I'm seeing one of the action taken, a pregnant woman who's lying in supine position, there was autocover compression. So just this lateral position can release the pressure, or a manual displacement of the gravid uterus can also release the compression and allow good blood circulation. So these are the simple things that you can do. And let's say that this lateral position should the patient lie in left lateral, not right? When you put your patient on left lateral position, that's why you optimize the circulation of the blood between the mother and the fetus, and that can help in improving the maternal and fetal well-being. For further discussion on how to take care of the patient who's in need of resuscitation during pregnancy, I'll call upon Dr. Opp to give us a case update and take us through the discussion.
Okay, thank you so much, Dr. Papytcho. So the case update reads as follows. Upon arrival to the hospital, we find that the patient has got continuous contractions. Her cervix is still closed. She has become more somnolent and is difficult to arouse. The following information is obtained on arrival. So because your facility is able to do an ABG, you collect blood for an ABG and you find that the pH is 7.34. The partial pressure of arterial carbon dioxide is 40. The partial pressure of arterial oxygen is at 100, and our patient is on oxygen at 10 liters per minute. And then the bicarbonate level in our ABG is 20. So I'll pause here before we go to the rest of the parameters. Remembering the physiological changes that we talked about earlier on, in pregnancy, we were told that parameters are different compared to the non-pregnant population. So I'll make a comment on the parameters we've been given. So looking at this ABG, we were told that pregnancy is an alkalotic state. So this ABG of 7.34, this is actually acidotic. So this patient has got some acidosis. The partial pressure of oxygen is 40. Compared to the normal at her gestation in pregnancy, this is markedly elevated. And then if you look at the partial pressure of oxygen of 100, this is reduced for the pregnant population. If you look at the bicarb level of 20, we were told earlier on when we were looking at the physiological changes, but that it usually ranges between, at this time, it's about 18. So this bicarb has slightly raised. So these are some of the parameters you need to look at when you're interpreting the ABG of a pregnant woman. So going back to the rest of her parameters, looking at her full blood count, we find that she's got, I think this is a leukocytosis of 20,000. So the white cell count is 20,000. The hemoglobin is at 9 grams per deciliter. So it could be hemodilution or it could be an anemia that we're dealing with. The platelet count is at 95. This is reduced. We know platelets should be 150 to 450. So 95,000 is reduced. Her C-reactive protein is elevated. We know that C-reactive protein is an inflammatory marker, so it's elevated. And then we look at the AST, ALT, and this is elevated. So we know that there's an increase in these liver enzymes. Looking at her chest x-ray, we find that she's got multifocal bilateral parenchyma opacities. So we know that there's something going on with our mother. So we proceed to do the fetal assessment. Sarah, please scroll downwards. Okay, just there, sorry. I think you've missed 3 lines. Just scroll back up. Okay, just there, thank you. So on the fetal assessment, the fetal heart rate is 155 beats per minute. The moderate variability with recurrent variable decelerations. This is on CTG. So all of this information you'd only be able to perform or get if your center has got access to ABGs or a CTG. But anyway, for the purposes of learning, in case you find yourself in such a center, we'll proceed. So I have a question for you. I hope we can all answer true or false as a poll. So it reads, scroll down, Sarah, please. The question reads, the following arterial blood gas is normal for this patient at this gestational age. We know that our patient is about 28 or is it 29 weeks, Dr. Papytcho?
She's 28 years and then 36 weeks.
Hello, Dr. Papytcho.
Hello, Dr. Opp just dropped off the call. Yeah, so we can continue it up. We're asking, is it true or false the following axial blood gas is normal for this patient at this gestational age? I could see some answers in the inbox. They're saying false, that's correct. This is abnormal, it's not true. Yeah, so it's false, the answer is false. This showing that there is acidosis as following at the reading on the different blood gas that we have here. We expect to have a respiratory alkalosis on such patient who are pregnant. Correct. Majority of our participants have gotten it in the right way. Thank you, Sarah. We can go back. We can go back and then we go up to the second question. Okay, so we give up the case update. Suddenly the patient loses consciousness and she's immediately intubated for hypoxemia and is transferred to the ICU. She has begun to contract regularly every 5 minutes. Her cervix is closed, but there is a small amount of blood noted at the vaginal introitus. The maternal vital signs that follows: temperature of 39, she's too febrile. The heart rate is 120, the blood pressure on the dropping side, 95/45, and SpO2 maintained at 95. She's put on mechanical ventilator, and the settings are on pressure control ventilation, the FiO2 of 70, respiratory rate 20, and the measured tidal volume 6 mL per kilo, and the PEEP is 10 centimeters of water. Okay, we can go up, Sarah. Please go up, Sarah. And then we said there's 105 heartbeats and then recurrent variable deceleration with minimal variability. So the question here is, if this patient were to go into cardiac arrest, which of the following modification is not appropriate during ACLS for pregnant patients? Choose the best answer. Thank you, Sarah. We can end up our poll. Okay, tilt the patient 30 degrees to the right during CPR. Is it right or left? This should be on the left side. Okay, so we got it correct. This should have been on the left side. So this one is not appropriate maneuver to do during patient resuscitation. The catch was on the side, not right, but on the left. So always remember to tilt your patient on the left so that you release the autocaval compression that comes with a gravid uterus. Please always remember during maternal resuscitation, even before you start your CPR, if patients are deteriorated in the ward, in labor ward, you want to optimize patient's general condition, you move her on the left side or left lateral, or you do manual displacement on the left of the gravid uterus. Thank you, Sarah. We can move on to the next question. And thank you very much to our participants for your active participation. So the next poll question is to know, in a crisis or clinical emergency, which of the following actions have you observed when providers cannot remember how to manage a certain clinical situation? Oh, wow, this is a nice one. What have you seen your colleague doing? What behavior have they presented if they can't remember what to do during resuscitation? Just be honest. And that could be you yourself. What did you do? Okay, I can't wait to see the answer for this poll. Thank you, Sarah. We can see the answers. Oh, everyone called for help. I thought somebody would hide and walk away. That would have been very funny and unprofessional. Or somebody have seen all of these. Somebody walking away, running away, or use the internet or phone or computer to check the ID. So I think from today onward, we all know that during emergency situation, the best, not only if you are not sure of what to do, but for better, for you to achieve the resuscitation protocols at ease, you need help. Don't engage yourself into a resuscitation maneuver alone. Always shout for help. Let's have more hands around so that we deliver the best we can during the protocol. Thank you, Sarah. We can go up. So in this book that we see here, it's a very interesting book. It got enough information on what to do during emergencies, obstetric related emergency. When you go on the website, you can download it and keep it for further use, and that you can read yourself, or you can even share with other colleagues. It's a very important tool that was developed by our colleague from Stanford University, and in collaboration with other partners, they developed this interesting manual that is ready for everyone to download. Thank you, Sarah. You can go up. So I'll call upon Dr. Ndaba to take us through this case update and further discussion.
Thank you so much, Dr. Papytcho, for that very interesting session. So we are moving on. As we wind up, we are going to look at the last bits of today's session. So further in the scenario, our patient is diagnosed with acute respiratory distress syndrome, ARDS, from presumed SARS-CoV-2 or COVID-19 infection. She is placed on lung protective ventilation settings on the mechanical ventilator, and the maternal fetal medicine specialists are following the clinical status of the patient and the fetus. So we are at this stage, we are not going to break into, we were supposed to have 2 breakout sessions, but I think we'll proceed to the next session straight away, where we invite Papytcho and Dr. Piri to talk about management of the pregnant mother with respect to the prone position. We know that prone position is one of the strategies that is used to improve oxygenation in patients with COVID-19. Now, the question we have is, what about a pregnant woman? After Dr. Papytcho's short discussion, then I'll come in and talk about the general care of a pregnant COVID mother briefly. So Dr. Papytcho, please kindly take it up and discuss with us prone position in a pregnant mother.
Thank you, Dr. Ndaba. Time to time, we are switching off camera to improve the internet. We're having challenges with our internet this side. As it was discussed in the previous session when we talked about ARDS, remember we said one of the strategies to improve oxygenation of the collapsed alveolars and to allow recruitment of more alveolar was to prone the patient. Now the question here is, how easy is it to prone a pregnant patient? As we know, proning position is when you put your patient sleeping on the abdomen and the back facing up. The challenge here is with the gravid uterus, which is so distended and then making it uncomfortable, almost impossible to put the patient in a prone position. But experts, clinicians have realized that proning a patient, even pregnant, it's got a better outcome than treating a patient with complicated COVID or any RDS from different origin in a supine position. Semi-prone also give a better outcome. So here down, there's a video. We'll check how you can prone up your pregnant woman. This video is teaching us how to go ahead during proning up a pregnant woman. Please, Sarah, let's watch the entire video.
We will be demonstrating.
I don't know if the video is going to want to work today, Dr. Papytcho.
Okay, if the video doesn't work, the link of the video can be shared, and then everyone who has a facility, enough bundles, you can see what's your video on your own time. But I'll just try and explain the easy way to make it. You might not be able to prone up a pregnant patient if you are alone or two. You will need a minimum of 4. The challenge here is that when we work, we are few on duties, but for such situation, this is a particular exceptional situation that we can have. You need to organize more hands for you to make your patient prone position. Remember, for you to make it easy, you need to prepare pillows, enough pillows that you put under the chest of the patient and pillows that you put under the hip. The pillows should be good enough to suspend the abdomen of the patient. If the abdomen is too big, they advise to put the patient in semi-prone position, but remember to be changing the position for the patient so that it's a bit more comfortable. Every 2 to 3 hours, you can change the patient position, and that will improve in terms of recruitment of dependent alveolus, which will now be participating in gas exchange. Remember, patient who's on ventilator, to improve oxygenation is to play with your PEEP and FiO2. The PEEP, the positive end expiratory pressure that you use, is to do more recruitment and to facilitate recruitment of alveolus. When you prone your patient, there will be that physiological recruitment plus the mechanical recruitment that you use with your PEEP. This is going to improve oxygenation and improve saturation and improve fetal and maternal well-being. And this can help your patient improve and then end up coming out from the complication of ARDS. Briefly, this is how you do it. And remember, when doing the manipulation, mobilization of the patient, don't disconnect the lines. Patient can be edematous due to pregnancy itself. Patient can be obese. Remember to take care of your lines, of your tube. Intubation might be very challenging because of the edema that comes along with pregnancy. Okay. That's the little that we would like to share, Dr. Ndaba. You can take it up for the general care.
Okay, thank you so much, Dr. Papytcho. As we wind up, briefly, I'll discuss on the general care of a COVID-19 mother. So the general care of a COVID-19 mother does not deviate significantly from the general care of any other patient, except that there are specific aspects of this condition that we might need to take into consideration. The most important thing, like is for every condition or every patient, is assessment. So assessment is key in determining the severity of the condition of the mother as well as the fetus. Because once you assess, you will know whether the mother has got mild COVID-19 or moderate COVID-19 or severe or critical COVID-19 as per WHO classification. That has bearing on what kind of treatment you are going to institute. So assessment is number one. The other aspect of care is the gestational age of the mother that might impact on how we are going to provide care for this particular patient. So once, remember again that pregnancy offers additional risks for progression into severe COVID-19. Pregnancy is in itself a risk factor for progression to severe disease. So that is something we also need to note once we have a pregnant patient who has got COVID. Because complications, again, such as venous thromboembolism, as well as respiratory failure, may easily develop in a pregnant mother. The other aspect of care that is key is, of course, close monitoring and follow-up, irrespective of the condition of the mother. Whether they are mild, they've got mild COVID, they need to be monitored very, very closely as well. So for a patient with mild or moderate COVID-19, of course, and we know that COVID-19 has got no treatment. Treatment is basically, has got no cure. Treatment is basically symptomatic. So you will treat based on the symptoms that the patient has. You may consider some analgesia, some antipyretic if they've got a fever. And then if they've got signs of lower respiratory tract infection and evidence of superimposed bacteria infection, you may consider some antibiotics as well. Now, the most important part is when you are now dealing with a severely ill COVID-19 pregnant mother. This means that you need a multidisciplinary approach like we discussed earlier, and also provide care for this patient in a high dependency unit or an ICU because of the risks that that the patient has. So we know in general that oxygen therapy for every severely ill COVID-19 patient is key and the most important form of treatment. And we've discussed oxygen therapy in previous sessions and how you can escalate based on the oxygen saturation and the oxygen requirements. Again, we also know that typically COVID-19 patients have got, they tend to develop this thromboembolic phenomenon, and pregnancy in itself is also increases or doubles that risk. And so patients should be placed on anti-coagulation, some form of anticoagulation drugs. So you may also consider some antibiotics as well as steroids, which may be beneficial for the treatment of COVID, as well as in the event that you want to mature the patient's or the fetus lungs, the steroid might also be of benefit. And then close monitoring, of course, is key. And then the multidisciplinary approach that we talked about should be involved. You need critical care specialists, you need obstetricians, you need infectious disease specialists to come on board as you provide care to this particular patient. Yeah. So again, please, there's a lot of literature related to this discussion. I just want to encourage all of you to just refer to this literature. The learning resource link has been shared into in our chat box, and then we'll have free access to this material. So thank you so much, Papytcho. I will give it over to you to conclude. Thank you.
Thank you very much, Dr. Ndaba. That was a nice summary and very important to know how to take care of COVID. Remember, we are going toward the 4th wave, and then we really don't know how it's gonna be. We're expecting it to be worse than the 3rd. We know how we're hit by the 3rd wave. So pregnancy with COVID, we've seen it before, and then we expect it to come. Remember, COVID will be with us for long. So to know how to manage a COVID patient in pregnancy is very important. The information is available on the resource centers. And then participants, please register for free. Encourage even other colleagues who are not on this call to register so that they can get the best information that is available there for free. So during this session, our practice change objective was to list the physiological change that occurs with pregnancy, to describe how physiological change of pregnancy affect maternal well-being. It was to describe how physiological changes of pregnancy affect disease presentation. We described the changes in arterial blood gases that occur during pregnancy. On this one, I know many of our centers do not have the blood gas, but this will not be a reason of you not knowing the interpretation of blood gas analysis, just in case you get to acquire it one of these days. The other objective was to list the goals of oxygen therapy in pregnancy. This is a very important point, and I'm sure we understand, added to the previous tutorials that we had on oxygen therapy. To recognize and describe signs of maternal distress. This is a daily bread we have to know, because pregnant women, they always present specific signs to alert us. Recognize and describe signs of fetal distress. This goes along with the previous point. List the multidisciplinary team members required for optimal care of a critically ill pregnant patient. It's true that in our remote areas, we don't have different cadres of different specialties, but the few that are available with the knowledge that we have, we can make up a better team and take care of our patients and improve the outcome. Describe the unique consideration during resuscitation. We emphasize it. Follow the protocols. Put your patient on left lateral or do a manual displacement toward the left. Utilize cognitive rate for obstetric emergencies. Be able to access COVID protocols for obstetric patients. If you don't have protocols, feel free to download them as they are available on the Learning Resource Center. Sarah, you can scroll down, please. Okay, so we'll finish our day with this saying from Rosa Parks: knowing what must be done does away with fear. So if we understand and know exactly what to do at the right time, you do it with confidence, and it will even give you more, it will give you better result on what you're saying or what you are doing. So at this point, I'll call up Sarah to close the session. I wouldn't say enough to thank our participants who really participated in today's session, and we call them and invite them for the next session to come.
Yes, thank you, Dr. Papytcho and Dr. Sipuka and Dr. Hope for this very informative and excellent session today. We covered a lot of really excellent material that will be helpful. So just a couple reminders. Everything that you saw today, all of the resources and the materials and the videos are all available for free on our Learning Resource Center. And the link has been provided in the chat. So please go make an account and access all of these resources to be able to use. The session recording and the link to the LRC will be shared via email later. And it's also on our website if you would like to access any of this materials later. A link to the certificate of participation will also be shared via email later. And if you'd like to join our WhatsApp group, you can scan this QR code here to stay updated, or you can message assist at this phone number. Thank you for joining today, and we hope that you'll come back next month, November 18th, excuse me, for essential emergency and critical care cases. So if you have any questions, please email echo@assistinternational.org. And we'd just like to thank our partners again, Project ECHO and Stanford University, and our excellent panelists for leading our session today during this very informative time. So with that, thank you all very much, and we will see you next month.
Thank you, Sarah. See you all next time.
Thank you, Sarah. See you all next month.